Assalamu alaikum everyone. I'm Dr. Shoaib, working as a vascular fellow in vascular department in Khan University, Karachi. Today I'm going to present abdominal aortic aneurysm, its general condition in general considerations, indications for its repair. Aortic aneurysms occur throughout the length of the aorta, with a majority occurring in the infrarenal segment. Thus, infrarenal portion is the most common area for the aneurysm in the abdominal aorta. Abdominal aortic aneurysms are at least 9 times more common than thoracic aneurysms. Approximately 1.7% of women and 5% of men older than 65 years have an infrarenal aortic diameter greater than 3 centimeter, and the incidence of aortic aneurysm increases by about 6% for each decade after that age, after 65 years of age, either in the man or woman. Definitions. A true arterial aneurysm is defined as an increase to 1.5 times the normal arterial diameter with involvement of all three anatomic layers. In the infrarenal abdominal aorta, an aneurysm is traditionally defined as a diameter greater than 3 centimeter or more than 50% larger than a normal proximal segment measured in either anterior-posterior or transverse dimension in a plane that is perpendicular to the longitudinal axis of the aorta. Epidemiology. Studies suggest a prevalence of aneurysm 4 centimeter or larger in approximately 1% of men between the ages of 55 and 64 years. This prevalence increases with advancing age by 2 to 4% per decade. It has been consistently demonstrated that abdominal aortic aneurysms occur with great frequency in men and those who are smokers, and if there is a family history of aortic aneurysm, so there are increased chances of abdominal aortic aneurysm in such population. Morphology. The shape of aneurysm is typically described fusiform, secular. Fusiform aneurysms represent a generalized increase in the entire diameter of the affected vessel. Secular aneurysms are more localized and often eccentric in shape. This is the diagrammatic view of the different types of aneurysm, such as fusiform. You can see the fusiform aneurysm is the dilatation that is involving the entire segment of the vessel or aorta, and other two are the concentric secular and eccentric secular, and you can see this is the localized dilatation of the involved part of the aorta. True versus false. The distinction of true or false aneurysms, usually termed pseudoaneurysms, is dependent on whether the lesion represents a dilatation of the entire vascular wall, that is true aneurysm, or is a locally contained hematoma resulting from destruction of the vessel, that is pseudoaneurysm. In pseudoaneurysms, the wall of pseudoaneurysm is connective tissue formed in reaction to the contained hematoma. Diagnosis. Diagnosis can be carried out by taking detailed clinical history. After physical examination often reveals a pustule abdominal mass in the thin lean patients. Other investigations are ultrasound, computed tomography, magnetic resonance imaging, angiography. This figure is showing ultrasound of the abdominal aorta that documents an abdominal aortic aneurysms noted with maximal measurement of 4.19 by 4.10 centimeter in the anterior, posterior, and transverse dimensions. This There is a CT angiogram of the abdominal and pelvis show an infrarenal abdominal aortic aneurysm measuring approximately 5.6 by 6.5 centimeter with extensive mural thrombosis along with right lateral aspect. The CT will tell the detail about the aneurysm extensive involvement and if there is any mural thrombosis that is residing inside the aneurysm. Rupture risk. Maximal diameter is the standard basis for the predicting rupture risk, with larger diameters associated with increasing risk of rupture. The UK small aneurysm trial reported an annual rupture rate of 2.2%, with most occurring in patients with an abdominal aortic aneurysm diameter of 5 to 5.5 centimeter. Risk of rupture, it is seen when there is control of hypertension and there is a stoppage of smoking, the risk of rupture is declined. Secular aneurysms morphology appears to portend an increased risk of rupture compared with fusiform type of aneurysm. Certain imaging characteristics on CTA can also indicate an increased risk of rupture. The characteristics are if there's presence of dissection, if there's mural thrombosis, or dissection of the peripheral calcification of the aneurysm sac. The UK morphology of ruptured abdominal aortic aneurysm study reported that most likely site of rupture is in the middle third of the aneurysm at the point of greatest diameter. This table is showing 12-month risk of rupture based on abdominal aortic aneurysm diameter, abdominal aortic aneurysm diameter in centimeter, and the rupture risk. If the diameter is between the 3 to 3.9 centimeter, then annual rupture risk is 0.3%. If the diameter is between 4 to 4.9, the rupture risk is 0.5 to 1.51%. If it is increased between 5 to 5.9%, then rupture risk is up to 1 to 11%. See, if the diameter is increasing, the rupture risk is also increasing. So the maximum risk for rupture when there is increase of diameter of the abdominal aortic aneurysm more than 7 centimeters. So rupture risk is around 30% per year. Indications for interventions. Size criteria for elective repair is when the size is 5.5 centimeters for men, when the 5 centimeter size for women, or when there is 12-month growth rate of equal to or greater than 10 millimeter in both sexes. Additional indications for elective or early intervention included if there is secular aneurysm, if there is dissection of mural thrombus, or the fracture of secular calcification. In this algorithm for clinical decision making, if there is abdominal aortic rupture risk is low, then go for surveillance of that particular abdominal aortic aneurysm. If the life expectancy is short, again go for surveillance. If there is increase or operative risk, then again surveillance is better. If the operative risk is average or low, then decide for elective repair, go for elective repair of abdominal aortic aneurysm. Elective repair. The choice between observation and prophylactic surgical repair of an abdominal aortic aneurysm for an individual patient at any given point in time should take the following into account: the rupture risk under observation, 2, the operative risk of repair, number 3, the patient's life expectancy, the personal preference of the patient, screening. In 2010, Organization European Society for Vascular Surgery, that according to them, there should be initial screening of men when age more than 65 with ultrasound. Men and referral for treatment, men should be considered for intervention when maximal diameter reaches more than 5.5 centimeter. Population screening for older female smoker does not reduce the incidence of rupture. Same in 2009, Society of Vascular Surgery tells initial screening for one-time ultrasound screening for patient aged more than or equal to 65 years. Screening recommended for the patient having first degree relative of history of relatives with abdominal aortic aneurysm. Referral for treatment, smoking cessation is recommended to reduce risk of abdominal aortic aneurysm growth and rupture. Elective repair is recommended for patient with the fusiform abdominal aortic aneurysm more than or equal to 5.5 centimeter in maximal diameter. In 2007, National Screening Committee UK, according to them, there should be initial screening with ultrasound for all the available men aged more than 65 or equal to 65 years. Thank you.
Yeah, thank you, Shoaib. That is very nice presentation. And I just wanted to go through that slide where they is showing that risk of how much is the risk with the size of the aneurysm. So this is very important table. So we see that if the size increases up to 5 and 5.9, the annual risk increases 1 to 11%. And if patient is having more than 7 centimeter aneurysm, it is there's one third chance that the patient is going to have rupture aneurysm within 1 year. So this is very good. And then the second table is your very relevant, that shows that beside this size of aneurysm, we have to decide the repair of aneurysm depending upon patient general condition, comorbids, and also patient choice, whether they wanted an operative or open or endovascular repair. Open has been thought to be a durable procedure, but it is associated with short-term increased morbidity and mortality. If there's any questions or queries, we can discuss of this presentation at this moment. Otherwise, we can move forward. The next presentation is of Dr. Ammar Pirzada. Yes, please.